This year for World IBD Day at IFCCA, we're going to continue our campaign IBD Has No Borders. And this campaign will focus on access to IBD care. What we really want to do with this campaign is to highlight the inequalities that people face worldwide in terms of access to treatment, diagnosis, and specialist care. And to put this into context, this campaign started 2 years ago in Mexico when we gathered with 7 patient associations from the Latin American region, where we really discussed the barriers and the challenges that associations and their members face in the region to access IBD care. And I would say this has been a really very successful meeting because we, first of all, realized that if we start talking together, we realize that some of the challenges and barriers are quite common, and that if we gather our forces together, we have a much better chance to actually improving the situation. And I'm pleased to say that one of the concrete outcome of the Mexico event was that our members from the Latin American region have now participated in one of the major congresses in the region with the medical societies, and they're working much closer together now in finding ways to improve issues around diagnosis, around access, and around access to specialist care. But if we look at the topic of access to care, it really depends also on not only, but also at the national level where you live. If you're in a big country like Spain, for example, and you live very remotely in the countryside, you don't have the same access to care as if you would live in a bigger city where the main IBD specialist care units are. So it's not only globally, but also nationally an issue.
From an Irish perspective, access to IBD care can look relatively strong when compared to some areas internationally, and it's important to acknowledge that we have incredibly dedicated and skilled clinicians working within the IBD services within Ireland. Speaking personally, I know I was extremely lucky when I was diagnosed with Crohn's disease, if you can put luck and a diagnosis of Crohn's disease into one sentence. Back in the late 90s, I was diagnosed with Crohn's disease of the large intestine. I was under the care, you see, of one of the best gastroenterology teams at the time, which is where the luck part comes into it for me. And I was able to stay as a paediatric patient, surrounded by my family and support network within Cork, which is where I'm based down south. That early access to specialist care made a real difference to my journey. However, today, paediatric IBD care is delivered in a much more centralised way now, with children being treated through the National Children's Hospital in Dublin. We absolutely understand the rationale behind centralising specialist care, that it's about clinical expertise and consistency. However, what we're actually seeing here in Crohn's and Colitis Ireland is the real life impact that this actually has on families. Parents are travelling long distances, taking time off work, arranging childcare for siblings, absorbing significant additional costs simply to access routine care. So that places enormous pressure on households, and it can actually create inequities that families have very little control over, because as we know, IBD is very unpredictable. More broadly, the IBD care system in Ireland remains fragmented, unfortunately at present. Patients often move between primary care, hospital services and different specialities with limited coordination, which means that care can feel reactive at times rather than proactive. Delays frequently start at the very beginning in the primary care setting, where symptoms may not be recognised early enough. Referral pathways to specialist care services then can actually be slow. So these diagnostic delays have long-term consequences, which lead to, obviously, as we all know, more severe disease, more complex treatment being required, and a poorer quality of life. Another significant barrier is that IBD is still not recognised under the long-term illness scheme in Ireland, despite it being a lifelong chronic condition. So that lack of recognition directly impacts equity of access to care and supports here in Ireland at present. It affects eligibility for medical cards, medication supports, travel costs, and financial protections, effectively shifting a substantial burden onto patients and families. For example, last year in Crohn's Colitis Ireland, we published a report with J&J highlighting the hidden costs of living with IBD to individuals and their families, which showed us just how much that burden is being absorbed by the individuals and households through out-of-pocket expenses, lost income, the requirement to have to travel to appointments, and unpaid care. So that financial strain matters because stress is a well-recognised trigger for IBD. People are experiencing system-created stress at a time when healthcare systems should be reducing pressure, not adding to it. We also continue to highlight the lack of fully resourced multidisciplinary teams across IBD services. So while we have excellent gastroenterologists and IBD nurses, the access to the dietitians, psychologists, social workers in cases, pain management specialists, this remains limited or unavailable actually at times, to be honest, for a lot of people. As we know, IBD doesn't just affect the physical body, it affects mental health, identity, confidence, education, work, yet the psychological support is still too often actually overlooked here in Ireland. Even in my own journey personally, despite I being grateful for the care that I have received even to date over the last 28 years, the absence of the coordinated multidisciplinary input and the limited communication that can occur between departments has had a lasting impact. There's been times where I have actually fallen between the cracks, to be honest, which has resulted in me having to, as I say, normalise certain symptoms that no one should have to normalise just to be able to get up and get on with my day to just push through. But there's only so much pushing through that a patient can actually do. For many patients, this means relying heavily on personal support networks, family, friends, carers. Not everyone has that village around them. That's why Crohn's Colitis Ireland this year, we're kind of doing our theme throughout this year of that it takes a village to live with IBD, with different events and everything that we're doing ourselves, just to highlight that as part of our advocacy work. Because living with IBD is not just about treatment, it's about having a system that works with you and not actually against you. And that goes from a policy level all the way down to just the general healthcare system. As a patient organisation and with the experiences from my own personal IBD journey, as I said, we're going to continue in our advocacy work for more proactive, joined up thinking approach to IBD care, from earlier diagnosis and primary care to proper recognition of IBD as a lifelong condition and access to fully resourced multidisciplinary teams. As I say, there's ways and means, and there's nothing impossible. It's a matter of having to think outside the box, because as IBD patients, we have to live our lives thinking outside the box just to have to get up and go through a regular day, whereas someone that doesn't have the condition don't have to do that. So that's why I always implore within advocacy and to healthcare systems of, just walk a mile in our shoes, and you could think outside the box fairly quickly if doing so.
Patient organizations play a much more active role and a strategic role in research projects like GENEGUT than simply being participants or just subjects. Their involvement is essential to making the research relevant, ethical, and impactful for patients. And specifically, what role do patient organizations play? So in projects like GENEGUT, patient organizations represent the patient's voice throughout the full duration of the project. So patients ensure that research priorities reflect real unmet needs. They co-design research activities, meaning that they contribute to shaping study design, outcomes, and communication, so they are meaningful and understandable for patients. So GENEGUT explicitly integrates a patient-centered approach, bringing patient organizations together with scientists, clinicians, and industry partners. And why are we involved? Why IFCCA is involved in this project? It is involved because it acts as the global representative of the IBD patients community, the national associations, and the patients worldwide. And its role in projects like GENEGUT includes integrating patient perspectives across the entire project lifecycle. So from the design to the implementation to the communication, IFCCA ensures that research reflects the real patient's needs, empowering patients to engage with science. So throughout initiatives like the IFCCA Academy, for example, patients are trained to understand and contribute to complex research topics like the RNA therapies, for example, and ultimately advocating for patient-centered healthcare and innovation, meaning that IFCCA ensures that outcomes improve quality of life and address real-world challenges faced by people with IBD.
Research is also important to understand the mechanism of the disease and how it progresses and how it's different from one patient to another. Because if we know how the disease works, then we are in a better position to design more targeted, more effective therapies. In GENEGUT, we're focused on the design of RNA therapeutics. We're all very familiar with RNA since the success of the COVID vaccine, but now we're using the same technology to apply it to a non-infectious disease like IBD. And we're hoping to give that medicine eventually by the oral route as opposed to by injection, which of course is much more convenient for the patient and should be a lot safer to use. IFCCA is a partner in the GENEGUT consortium and a very valuable partner, because when we as scientists are designing medicines, we have to ensure that the patient's needs are met, that the medicine that we produce at the end, for example, an oral product, is acceptable to the patient. Because if the patient doesn't want to use or cannot use the medicine, then it's effectively useless. So the patient input is crucial in the design of the medicine. The other thing that's important in GENEGUT is communication with the patient community. And again, by collaborating with IFCCA, we ensure this. We've had joint sessions with IFCCA, and we've also had joint sessions with the Irish Crohn's and Colitis Association. It's important, I think, to communicate the research to the patients so that they're informed about the possibility of new approaches to therapy. And even as is the case in GENEGUT, our products are more long-term. It still gives the patients hope that the future looks brighter. And if, for example, the medicine is not ready for their generation, it can help the future generation. So communication is vital, and we achieve that, we hope, efficiently through the GENEGUT and the IFCCA and Crohn's Colitis Association interaction.
Let me answer that. What needs to change going forward? Well, I think what needs to change is so that we can move forward, is to move from awareness to action. So we already know many of the challenges patients face, like delays in diagnosis and unequal access to care. And I'm glad that our colleague from Ireland mentioned a lot of very concrete issues and examples. But I think now we need to turn that into concrete solutions. That means listening to patients, involving them in decisions, and strengthening global collaboration. So, because if we work more closely together, we can improve access to care faster and I think more effectively.
From a research point of view, I think the important thing is obviously we need to see more funding coming from the different funding agencies to keep our research active. But what's also important is that we have a multidisciplinary team involved in the research projects. So we cover all bases, including the patients, so that the outcomes and the impact of the research is more realistic.
And just to second what Isabella said, I think from even the Irish perspective, and I know I touched upon it earlier, but we firstly, what needs to change is very clear for us. IBD must formally be recognised in Ireland as a lifelong chronic illness. So access to care and supports don't just depend on how hard someone can actually fight the system to get those supports. Secondly, we actually need the proper resource to multidisciplinary IBD teams here as well across the country, because as I said earlier, IBD just doesn't affect the physical, it affects the mental health as well, nutrition, work, family life, well-being. Care pathways should reduce stress, not add to it, especially when we know how closely stress is linked to disease activity. And finally, patients must be listened to as partners in policy, healthcare planning and research.